those mechanisms that keep the antibiotic from working, they've gone away when we break it open and release the bacteria to become planktonic or free floating.
Back on testing, if the organisms in a biofilm are hard to detect, how do you choose which antibiotic to start treatment with? And are there indications over time that it might not have been the right choice because whatever organism is actually causing the symptoms wasn't detected?
Yeah, great question. So this is why I sort of changed my practice probably like 9 months ago when I
Hmm.
was talking to Ruth one day, and she was like, I don't treat without doing like a week of biofilm disruption beforehand because I'm just going to need to do another one after. And like the testing is expensive. So I also try and, consider like and be frugal.
Hmm.
And so I use the biofilm disrupting agents usually a week before taking any samples or doing any sort of testing as tolerated by the patient,
Hmm.
because when you break open a biofilm, it can obviously cause symptom aggravation. You're evading these bacteria from their nice, cozy home so they can get angry. So if they can survive for like the week and we get a better sample, that's great. But sometimes it's only 3 days and that's okay too.
Hmm.
And then the PCR testing, like microgen, can detect bacteria inside biofilms even without disruption. So usually with that like added piece of treatment, I get a good picture and can see everything that needs to be treated. So that's how I know what I'm treating. Um, and then PCR is, of course, more useful than like a culture, but I have worked with people who couldn't access microgen, and
Hmm.
then we would use the biofilm disruptors and we would basically provoke a positive culture
Hmm.
to see what was in there. And that works too. Like if you
Okay.
break a biofilm, you can see it on culture.
Are there particular types of biofilm disruptors that you do use?
Yeah, so um, in Canada, I only have access to like certain ones. You kind of got to work with what you've got. So after testing, I usually will use fibrinolytic enzymes such as lumbrokinase, nattokinase, serrapeptidase. Lumbrokinase is the strongest one, so it's about 12 times stronger than nattokinase. So I opt for that one when I can.
Hmm.
Um, and then the reason why is because fibrin is part of like our clotting system, and it's basically what makes the clumps. Fibrin is also what attaches the biofilm to the bladder wall. So we kind of have to like shave that fibrin off,
Hmm.
get the biofilm off the wall, and then dissolve the biofilm itself with other disruptors. So I always start with some sort of fibrinolytic enzyme away from food. And then I use NAC or N-acetylcysteine for curly biofilms. So that's the type of biofilm that's secreted by things like E. coli and Klebsiella. And basically NAC, I'm very nerdy and I love to like explain
Hmm. No,
mechanisms of
it's
things.
great.
But NAC has like a sulfur and a hydrogen atom, and
Hmm.
so do the polysaccharides are like a disulfide bond, so two sulfurs. So the NAC will break open that disulfide bond by donating a hydrogen, allowing the biofilm to, break open and dissolve. So I'll always use NAC for curly, and then I will always use bismuth or black cumin or ALA for the extracellular DNA biofilms, which are in Serratia, Klebsiella as well, has both. So I just, based on the bacteria, I'll
Hmm.
see what biofilms they make, and then I'll match the disruptors and like the timing. It's all a very, very complicated process.
Sounds
Yeah.
like it. So some people might need to use more than one type of disruptor depending on what organisms you've identified.
Yeah, and if it's a polymicrobial infection, for sure. But it does work well. If they can tolerate both and use both, that's awesome.
Hmm.
Also, a lot of bacteria will create ammonia or some people genetically will create more ammonia, which will sit in the bladder overnight, causing a lot of irritation.
Hmm.
And so you can use L-ornithine or L-citrulline to convert the ammonia back to urea, I believe. And this also helps with like sometimes color, smell, cloudiness.
There's a lot of conjecture about orally administered biofilm disruptors. How do you know they actually reach the bladder if we don't have the research to support that yet?
Yeah, that is a really good question because there is very limited evidence, and so most claims are just mechanistic or
Hmm.
anecdotal. Most enzymes are enteric coated, so they will survive the stomach acid and then be absorbed by the small intestine into your systemic bloodstream. And then for concentrations, yeah, we don't know. We don't have a test for like how concentrated it would get in the bloodstream. I can say not evidence-based, but clinically in my practice, I've just seen this work time and time
Hmm.
and time again in 100 cases. So I feel very confident using it. But I do understand like the hesitation or like wondering where it comes from or if it's working for sure. Um, with NAC, I believe there are studies not related to UTI, but how concentrated it gets in the bloodstream
Hmm.
and that it's used as a mucolytic or like to treat mucus and cystic fibrosis.
Hmm.
So there's other applications of NAC that we can mechanistically relate to the biofilms in the bladder. And then as for bismuth, that one we also don't know a concentration, but we can see on like tissue samples.
Hmm.
Mhm.
So it's based on extrapolation from other research and then watching what happens in clinical practice. Do you
Yeah.
think that using the biofilm disruptors also help with antibiotic therapy or make antibiotic treatment more effective?
Yeah, for sure. That's what I've seen because I initially in practice, like I've seen cases where I had given like 2 weeks of antibiotics without disrupting the biofilm, and that didn't work.
Hmm.
And I've done it where I've given 2 weeks of antibiotics in the same case while disrupting the biofilm, and it went gangbusters, like completely different story. So I do think it changes the way the antibiotics work because
Hmm.
when we talked to how the biofilms affect antibiotics, like it's a low oxygen, low nutrient environment, it's a gelatinous goo, so it slows transit. All those mechanisms that keep the antibiotic from working, they've gone away when we break it open and release the bacteria to become planktonic or free floating. And so it allows the antibiotics to actually see and kill the bacteria there. There can be another difficulty, which is if there's cell wall deficient bacteria. So this usually happens after someone's had a course of antibiotics, and this is part of what creates resistance. So a lot of antibiotics, the way they work is that they affect the cellular machinery of the cell wall of the
Hmm.
bacteria, like the pumps. They stop the pumps, it like breaks the wall, the bacteria breaks open and die. But when the bacteria learn this and they're like, oh, this is what you're gonna do, I'm just gonna live without a cell wall. Um, and then they can still wreak havoc, but now they don't have the
Hmm.
cellular machinery that you're trying to attack. So those either it takes time, you have to give time for the cell wall to grow back, for them to become comfy again, and then they're like,
Hmm.
okay, I can get my wall back. Or I will use herbs because herbs don't create resistance like antibiotics do. I always explain herbs like um, a myriad of constituents. So antibiotics might be one ingredient that's very simple to create resistance to, whereas a herb is thousands of constituents
Hmm.
that create a very complex picture, and it's way too much for a bacteria to try to figure out. It's too complicated.
Hmm.
So they can't figure it out, and that's why we haven't really seen resistance to herbs as of yet, knock on wood. So if I'm thinking there's cell wall deficient bacteria, I'll opt for herbs, at least for a little while to give symptom relief.
Hmm. That's another point that a few people asked. If part of the problem with the immune system not being able to reach the bacteria is because they're in biofilms, could you just use a biofilm disruptor and then hope that the body can clear it without additional antibiotic
Mm,
treatment?
yeah, I love this question too. So I actually have seen this happen
Hmm.
multiple times. And the first couple times it did surprise me because we had done like a microgen and everything, and I thought, okay, this, we're gonna treat it. And then they would do the like week beforehand where they take biofilm disruptors before they take their samples. And
Hmm.
then they would come back in to drop off their sample or what have you. And they'd be like, yeah, all my symptoms are gone. And I would be like, what? And they're like, I feel the best I've ever felt. And I'm like, huh, like they're only on the enzymes or they're
Hmm.
an NAC or something. And yeah, so I did have one case where I was like, let's just try it and just like stay on the biofilm disruptors, drink lots of water. And I think we had treated it a few months prior as well with antibiotics. So it might have just been like not a very robust infection or like not a lot of colonization. And it fully went away.
Great for that
So
person.
yes, very great. Um, so yeah, it can happen. Like if you break open the biofilm and then say you've got like D-mannose on board and water
Hmm.
or like a herb, yeah, I've seen it happen, which is really cool.
For patients who aren't keen on more antibiotics, do you sometimes just use the biofilm disruptors and herbs from the beginning?
Yeah, sometimes my hands are tied to just like in Nova Scotia where I don't have prescription
Hmm.
rights. We have to opt for that and usually work alongside their GP or their other specialists
Hmm.
to try and get them the best care I can. But yeah, I've also just used biofilm disruptors and herbs. And I was sort of put against that when I started this work. Like Ruth had mentioned, she didn't think the herbs worked well enough.
Hmm.
Um, my other colleagues had mentioned it, and I was like, okay. And then, my hands were tied, so I sort of started using it, and it
Hmm.
works really well. Um, it just takes more time. So with the
Hmm.
antibiotics, I can usually figure out the majority of the infection and resolve it in like 2 or 3 weeks. And then just like a lot of aftercare to prevent reinfection. With the herbs, it'll usually take like a month or two, but
Okay.
over those month or two, it gradually gets better. Like it gradually resolves. So most people are very happy at the end and they don't have like as many symptoms per
Hmm.
se as like with antibiotics causing diarrhea, tendon issues, headaches, that sort of thing.
Does some herbs come with side effects like that though for some people?
Yeah, they can. So like berberine can cause a bit of diarrhea because it will kill off some good bacteria in the gut.
Hmm.
So I still use probiotics even with the like antimicrobial herbs.
Hmm.
And I always try and like watch closely for any side effects. I also try and watch the probiotics for cytolytic vaginitis.
Hmm.
Like I don't want them on lactobacilli for too long, like not more than 6 months without a break at least.
Have you seen the cytolytic vaginosis happen a lot in people that have taken them for too long?
Yeah, time and time again. And it's usually like they'll come in to my office and I haven't seen them before.
Hmm.
They will have been taking them for a year or two and then have a
Hmm.
lot of vulvar symptoms. And I'm like, okay, time for like a pause on that, use a different strain or like use some other methods. But yeah, I do see a lot of cytolytic vaginitis.
And we should also clarify what that is for people who aren't
Yeah.
familiar with it because it's kind of new in the research field as well.
Yeah, so cytolytic vaginitis is basically like an overgrowth of lactobacilli in the vagina that can cause symptoms that look really similar to a yeast infection, like redness, itching, irritation. It won't have that clumpy discharge that a yeast infection will. And so usually you can see that on a microgen vaginal swab, or I
Hmm.
have seen it on just like a regular like hospital testing swab here as well, where it'll say lactobacilli, the amount of colonization, or like high load.
Hmm.
So that requires usually a baking soda douche. Um, there's also another type of vaginitis called aerobic vaginitis that
Hmm.
can happen usually in menopause where there's tissue change. So I always kind of look out for those and try and differentiate them. Aerobic vaginitis needs 2% clindamycin,
Hmm.
which I try to avoid when I can because clindamycin just kills everything. It's like
Hmm.
a scorched earth effect.
Yeah.
And so if I can treat it in a nicer way, I try to. Sometimes it's necessary.
Yeah, I think so, especially when it comes to patient quality of life. Patients have to be part of that decision-making process. And I think a lot of patients would choose that treatment if it helps with their symptoms. But that's a good segue into
Yeah.
the next question, which is about trying to repair after treatment, the gut
hmm
and the vagina and the bladder. You've mentioned
hmm
probiotics. I'd love to know what probiotics you usually go to if you have go-tos, but also if there's other approaches you use to help repair afterwards.
Yeah, totally. Also not like sponsored by any company or anything, but in Canada, I like using Zymogen 100 billion, which is a mixture of Lactobacillus acidophilus, plantarum, Bifidobacterium, bifidum, and I forget the fourth one, but there's a
Mhm.
fourth one because those are like the it's a high amount, so it's 100 billion versus some people come into my office and they're either on probiotic gummies, which is a
Mhm.
no-no. They've probably all died in the cooking process.
Mhm.
And then they might come in and be on like a 12 billion or 30 billion,
Mhm.
which probably isn't high enough for them if they've been on antibiotics a lot.
Mhm.
And so a higher dose and then lactobacillus or bifidum strains because that repopulates like the kidney and the bladder microbiome. I will use Espoulardi if they've had any like diarrhea associated with the antibiotics. Sometimes I'll use lactobacilli suppositories vaginally, or you can break open lactobacilli and put it in like an estrogen cream and
Mhm.
rub that vaginally. For aftercare, usually I will st like once the antibiotic stops, I'll continue on the biofilm disruptors for another week or two because I don't want to go cold turkey. I want to
Mhm.
try and like keep resolving if there's any leftovers. We don't want to leave any single crumb behind.
Mhm.
And so I'll stay on the biofilm disruptors and then sometimes we'll add in like a herb maybe for just like a little bit of killing if something comes out.
Mhm.
I have this fantastic book called Herbal Antibiotics, and it has every bacteria and then which herbs have been found in research to act against that. So, for example, garlic and E. coli are pretty well researched. I have a list for like Proteus or Serratia and what herbs act on them. So
Mhm.
I might add that in if needed. And then I keep them on the probiotic for a month or two after their antibiotics and just lots of water and other home care.
Is that Herbal Antibiotics book the one by Stephen Booner?
Yeah.
Yeah, just in case other people are interested. I've also seen that
Yeah.
book and it does seem to be very detailed.
It's really useful. He is, yeah, a true talent.
There were a couple of questions that I don't want to skip over before we get to the end, which was about spinal cord injury. A lot of patients in our community have indwelling catheter or they rely on catheterization or they have neurogenic bladder. And so we did get a few questions about that. So the first one was for people who do rely on catheters, such as those with spinal cord injuries, how do you approach chronic UTI treatment?
Yeah, I have quite a few patients that use catheters as well. And so I treat them in a similar fashion. as if they didn't have a catheter, like
Hmm.
pretty similar. So biofilm disruptors, probiotics, antibiotics, if it's an acute infection that we find. Um, when we're trying to resolve like an acute infection and they have a UTI, I usually recommend that they use the sterile single-use catheters, which are more pricey, but just for
Hmm.
trying to resolve infection, I don't want to have any like causative factors that could reinfect them. And so I'll opt for those, and then I'll usually go over sterile technique with them again, just to make sure
Hmm.
we aren't missing any piece of the puzzle, like if there's some sort of causative factor in how they're using the catheter. And then occasionally, if it's a tough infection, I'll treat the biofilms with catheter-associated UTIs more aggressively
Hmm.
because I think there's likely a biofilm inside the bladder and the urethra. I also meant to mention that biofilms can exist on the urethra and be a real bugger. That's what
Hmm.
causes all those urethral symptoms and where you can like feel your urethra in space wherever you are. Um, and then there's also like a biofilm on the catheter itself,
Hmm.
especially if it's indwelling. So sometimes just a little more aggressive if they can tolerate it.
The urethral biofilm is an interesting one because a lot of people say they only have symptoms right around the urethral opening. How do you
Yeah.
treat that given antibiotics would just go straight past as you pee?
Yeah, that's a good question. I see this a lot too. Like that's what most people come in my office with, and they're like, I can feel my urethra in space. And so it's similar. Like you can still use antibiotics orally and the
Hmm.
biofilm disruptors because it probably is in the bladder too. They're just not like as symptomatic in the actual bladder. And then for the urethra, sometimes I'll make like a compounded cream. So antibiotics and like a Mucilux or a Versa base. Those are just like pharmaceutical bases rubbed around the urethra, estrogen around the urethra if it's a female and it's indicated,
Hmm.
um, to try because estrogen will bind to the receptors in the urethra and it increases lactobacilli's content
Hmm.
in the urethra, which will try and outcompete with the bacteria that's there as well. A lot of water. Yeah, we just try like everything under the sun to get it treated in that area because yeah, it is tough. Um, I've had another one who had like urethral scarring and
Hmm.
calcification, and we ended up using high dose vitamin K2. There's some research in Japan on using this for osteoporosis for like calcification resorption.
Hmm.
And it was theoretical, but we like ran out of options basically. And so I was like, well, let's try it. Like this minimal risk. It was an elderly person with osteoporosis already. And on the follow-up cystoscopy, we did see more resorption of those calcifications and more relief in the urethra.
Hmm. Interesting.
But yeah, urethras are a little tricky.
Do you diagnose the urethral biofilm based on symptoms alone, or do you swab that area?
Both. So yeah, we can do a swab, symptoms, and then usually I'll recommend a cystoscopy so like we can get a look
Hmm.
at the urethra as well. Sometimes those are hard to access in Canada, though. They take a long wait time.
Okay. Yeah, that's interesting. One of the questions about biofilms is that are there natural biofilm disruptors or food-based biofilm disruptors that people can take, and should
Mm.
people take them long term?
Yeah, so there are like food-based biofilm disruptors. The caveat is just that they might not be strong enough to like fully eradicate a biofilm, but they
Hmm.
can be like very supportive during treatment and helpful. So some food examples include pomegranate, black cumin seed or black cumin seed oil, garlic, cranberries, turmeric, ginger, manuka honey. Of course, if you're going to start any supplements, see a physician, make sure it's dosed appropriately.
Hmm.
Um, so those are like some food examples. And sorry, what was the second part of the question?
Should people take them long term? if they
Oh,
think they're
long term.
helping?
If they think they're helping, so you can take them long term. They're like a food. Most of them are antioxidant.
Hmm.
The safety piece would just be dosing. So with things like ginger or garlic, they are blood thinning. So you don't want to combine them with any sort of blood thinning medication
Hmm.
like aspirin, apixaban. You need to be careful around that. Um, Manuka honey has, sugar content. So if you have diabetes, which a lot of chronic UTI patients do have
Hmm.
concomitant diabetes, you want to be careful around that. I think it depends on the, individual picture, other health
Hmm.
concerns. But yeah, in small doses or in food, they can be continued.
Okay. Well, this has all been very interesting and has answered a lot of the questions that were submitted by the community. So thanks again for that. I
Yeah.
wanted to, though, quickly ask you how people can get in touch with you to make an appointment if they'd like to.
Oh, yeah. So I work at a clinic called Integrated Health Clinic in White Rock, BC. So you can find me there in person or virtually if you live in BC. And then in Nova Scotia, I work at a clinic called Naturopath Wellness that's in Dartmouth. And so that is all virtual, and you can find me there. Um, I also do like some consulting work for people who reside outside the province, so I cannot act as your physician, but I can answer questions and explain research to you. So that is also an option, and you can reach out to me if you'd like that.
I've put the links to both practices in the video description so people can find you more easily.
Yeah, great.
Thanks so much for watching. I hope you found this expert video helpful. If you'd like to learn more about this or related topics, be sure to check out our other videos or head over to liveUTIfree.com for related articles. We'll drop some links in the video description. If you like what we're doing on this channel, you can support our work by hitting subscribe here on YouTube, and don't forget to tick the bell so you'll be notified of our future videos. Thanks again for watching, and until next time, keep asking questions and pushing for better solutions.